Part 1: Suicide Statistics at the National Level. Today, we begin with the data. When we talk about suicide, we are not talking about a marginal issue. We are talking about a major public health crisis in the United States, one that affects every age group, every region, and every socioeconomic class. According to the Centers for Disease Control and Prevention, the most recent finalized data show that the United States records just under 50,000 suicide deaths per year. That places suicide consistently among the top 10 causes of death nationwide and among the leading causes of death for adolescents, young adults, and working age adults. The national age adjusted suicide rate sits at approximately 14 deaths per 100,000 people, with modest year to year fluctuations. While there was a slight dip during the early COVID-19 period, rates rebounded sharply by 2022 and 2023, and only very recently show a small provisional decline. Age patterns suicide risk is not evenly distributed across the lifespan. Among children under 15, suicide remains statistically rare but deeply concerning, particularly because it is now one of the leading causes of death in early adolescence. Rates rise sharply in older adolescents and young adults, especially ages 15 to 24, where suicide ranks among the top 3 causes of death. Among adults 25 and older, rates increase further, with particularly high risk among middle-aged and older men. In short, youth suicide is tragic and rising, but the highest absolute burden remains among adults. Sex differences. One of the most stable findings in suicidology is the gender disparity. Men die by suicide at roughly 4 times the rate of women. Women report higher rates of suicidal ideation and attempts. This gap widens with age and is strongly associated with method lethality, especially firearm use. Method. More than half of all suicide deaths in the U.S. involve firearms, followed by suffocation and poisoning. This matters because method availability strongly predicts fatality, even when intent levels are similar. Geographic and demographic patterns. Suicide rates tend to be higher in rural areas than urban ones. Elevated risk is observed among certain populations, including American Indian and Alaska Native communities, veterans, and individuals experiencing socioeconomic instability. No demographic group is untouched. The takeaway from the data is simple but sobering. Suicide is common, preventable in theory, and stubbornly persistent in reality. And that brings us to Part 2. Part 2: Problems with the National Strategy to Curb Suicide. Tone shifts slightly: analytic, critical, systems focused. The United States does not lack a suicide prevention strategy. In fact, we have a national strategy for suicide prevention, updated and supported by federal agencies, public health institutions, and clinical organizations. So why haven't suicide rates fallen in a sustained way? The answer lies not in intentions, but in structural problems. 1. Implementation gaps. One of the most frequently identified problems is uneven implementation. The national strategy sets goals, but states, counties, hospitals, schools, and community systems adopt them inconsistently. There is no single enforcement mechanism, and accountability varies widely. As a result, best practices exist on paper but fail to translate into uniform action. 2. Identification failures. Many people who die by suicide had recent contact with healthcare systems, including primary care or emergency departments. Yet, suicide risk screening is inconsistent. Warning signs are often missed. Follow-up care after crises is fragmented. In short, we frequently see people, but fail to see risk. 3. Workforce and access shortages. National strategies depend on trained professionals, but the U.S. faces severe shortages of mental health providers, long wait times for care, rural and underserved communities with little or no access. A prevention plan without a workforce is aspirational, not operational. 4. Over medicalization of suicide. Another problem is conceptual. National strategies often frame suicide primarily as a mental illness outcome, which neglects social, economic, moral, and existential contributors, underemphasizes grief, moral injury, trauma, and isolation, can alienate communities who do not experience their distress as psychiatric. Suicide is not only a medical problem, it is a human problem embedded in social systems. 5. Stigma and cultural barriers. Despite public campaigns, stigma remains powerful. Many individuals avoid seeking help, fear professional consequences, distrust institutions, come from cultural or religious backgrounds where suicide is taboo or silenced. A strategy that does not deeply engage culture cannot reach those most at risk. 6. Data and surveillance limitations. Ironically, we often learn about suicide years after it happens. National data lags behind real time needs. Subpopulation data is limited. Local systems lack rapid feedback loops. This makes prevention reactive rather than proactive. Closing synthesis. To summarize, Part 1 showed us the scale of the problem. Part 2 explains why scale alone does not produce solutions. The challenge of suicide prevention in the United States is not a lack of compassion or awareness, but a mismatch between complex human suffering and fragmented systems of response. If we are serious about reducing suicide, we must move beyond slogans and toward integrated care, community based approaches, moral and social repair, sustained follow up, and realistic implementation strategies. In future lectures, we'll explore what actually works and what prevention looks like when it is done well.